Hi, this is Dr. Pedro Ramirez, editor-in-chief of the International Journal of Gynecological Cancer. And today I have the great pleasure of speaking with Gabriel Levin, who is at the Department of Gynecologic Oncology at McGill University in Montreal, Canada. Gabriel is actually the lead author, and I'm also a co-author on this very important study that was published recently in the American Journal of Obstetrics and Gynecology, the great journal. And the title of this article is Approach to Radical Hysterectomy for Cervical Cancer After the LACC Trial and Associated Complications, a National Surgical Quality Improvement Program study. Gabriel, it's great to see you. Thank you so much for accepting our invitation to doing the podcast. Really looking forward to discussing our paper in this podcast.
Hey, Pedro, thank you so much for having me. It's always a great pleasure and honor to work with you, and I'm humbled by the invitation and excited.
Excellent. So, Gabriel, let's start by discussing the results of the LACC trial and also providing outcomes as it pertains to disease-free survival in our recent publication in the Journal of Clinical Oncology on the overall survival of the LACC trial.
Thank you, Pedro. Well, the final analysis of the overall survival of the LACC trial was published at the end of this May, as you said, in the JCO. Generally speaking, 319 patients treated by MIS RADHIS versus 312 with open surgery. The rate of disease-free survival at 4.5 years was 85% in the MIS RADHIS versus 96% in the open surgery group. This is a hazard ratio of 0.25 in favor of the open surgery. This remains significant after adjustment for age, BMI, stage, LVSI, lymph node involvement, ECOG status, and the rate of overall survival was 90.6% for MIS RADHIS versus 96.2 in the open group. Hazard ratio for disease-specific survival of 0.38 in favor of open surgery. The rate of local regional recurrence was higher in the MIS with a four-fold effect in tumors larger than 2 centimeters, and the rate of carcinomatosis was higher as well in the MIS RADHIS.
Excellent. So thank you for that overview, Gabriel. And I want to ask you this next question. Of course, obviously, you brought this idea to the group. What was the impetus for the current study? What did we know from prior literature about trends in radical hysterectomy in the U.S.?
The results of the LACC trial were first reported in the SGO 1918, late breaking abstracts, right? And since then, the literature shows a significant decrease in MIS RADHIS. This is natural. This was first published by the University of California, San Diego, the CHARO trial study, using the VISINIT database. The annual rates of minimally invasive hysterectomy fell by half after the LACC abstract publication. And we have recently the Shivardi paper, also published in the IJOG in January 2024, showing a decrease in MIS hysterectomy from 75.6% before the LACC to 41% after the LACC. Regarding the impetus for performing this study, there are several factors. The Shivardi paper, which was the latest paper, it analyzed data only until 2020. That means only 2 years or less of a follow-up post-LACC trial. Plus, there were some discrepancies of the results data with the CHARO paper describing the rate of 27% MIS post-LACC, and the Shivardi paper describing 41%, significantly higher. So delving more into the Shivardi paper, they actually analyzed all hysterectomy cases, not specifically radical hys, which is the population of the LACC trial. So taking into consideration the follow-up period and the cohort analyzed, we felt there is a need for a more focused analysis to answer the question.
Excellent. So ideally, coming closer to the LACC trial population and giving us a really an update in terms of time frame. So now share with us what was the study design in this context, and also for perhaps our international audience, why did you use the NISQIP database?
Thank you, Pedro. Of course, this was a retrospective analysis. We included patients who underwent radical HIS during 2012 to 2022. We included only patients operated by the gynecological surgeon. We excluded vaginal radical hysterectomies. We defined the pre-LACC period as 2012 to 2017, excluding 2018. And the post-LACC trial, the period was defined as 2019 to 2022. For the purpose of the study, we used the NSQIP database. It's a large database, extremely large, US-based. It operates in more than 700 hospitals in almost all the states, 49 states. What's interesting in this database that the program deploys abstractors within the participating hospitals, which actually call the patients at 30 days to determine the surgical morbidity and mortality. This database is not administrative. That means it doesn't collect data from insurance claims. And it's, as I said, extremely large, so it gives you enough statistical power to study rare events and complications. For this, I can recommend your audience to read the paper about secondary databases in Gyne-Onc, published at your journal. I really recommend it. It's a great paper.
Excellent. Yes. And we are actually looking forward to also having a podcast on that manuscript, providing details on databases as well. Now, why did you consider that evaluating rates of complications was also an important endpoint for this particular study?
Thank you, Pedro. Well, the literature on the effect of the LACC trial on postoperative complications is controversial. We can recall the Obermeyer paper in the IJOG in 2020, analyzing the LACC trial itself. He's a co-author on the LACC trial as well. In the open surgery, open radical HIS, we can see higher rate of cardiac events and wound complications. And with MIS radical HIS, we can see more vaginal vault complication. This is per the Obermeyer paper. Well, both NSQIP studies evaluating post-op complications had some inclusion criteria which are not aligned with the LACC population, as we just discussed, the Shivardi paper. What's interesting when you delve into the data, that the Shivardi paper included only 18% lymph node procedures. And the paper by Matsuo, a great author as well, he analyzed hysterectomies, not radical. And it is important to see whether the LACC trial, this practice-changing study, had implications also on postoperative morbidity.
Excellent. So now share with us the results of this particular study, and what are some of the main highlights you want to discuss in the study? And of course, obviously, as you mentioned, a very large study, 3,611 patients.
Thank you, Pedro. Exactly as you said, 3,611 patients were analyzed. And we see a decrease in the rate of MIS radical HIS from 75% in 2017, 1 year before the abstract publication, to 11.4 in 2022. Regarding complications, the rate of major complications didn't change after the LACC trial, with 7.4 before and 5.8 after the LACC trial. The rate of blood transfusions increased from 7.3 to 9.8, and the rate of surgical site infections also increased from 1.1 to 3.9. And these two complications, the blood transfusion and the SSI, surgical site infection, were the major drivers behind an increase in minor complications rate, only from 16.9 to 21.3 after the LACC trial. When we performed the logistic regression analysis, the route of radical hysterectomy was not independently associated with the occurrence of major complications.
Well, I think, certainly as you have highlighted these important findings, one of the first questions that comes up, and actually we've had some discussions here in our own institution at Houston Methodist, is, obviously this study demonstrated an important trend towards fewer minimally invasive radical hysterectomies. However, there are some who say 11% of patients are still undergoing minimally invasive surgery. So why do you think there's still an 11% being performed by MIS? Is there really any indication for MIS in any patient today undergoing radical hysterectomy?
Thank you, Pedro. This is a $1 million question, right? I'm not the type of surgeon that argues with level 1 evidence. I mean, I don't argue with it. I know some surgeons that do argue with it. I can think on several reasons why there is still debate and why some centers still practice MIS rad-his in cervical cancer. Maybe it's patient selection. Some patients may be better candidates for MIS surgery, maybe based on tumor characteristics. I mean, very early stage disease or small tumor size, less than 2 centimeters. Some surgeons say this is the cutoff. Or perhaps individual health factors as poor wound healing. Of course, surgical expertise. Some surgeons are highly skilled in MIS techniques and may feel confident in their ability to achieve good outcomes. And the benefits of MIS is short hospital stays, reduced postoperative pain, quick recovery. For some patients, these factors may weigh highly in the decision. Regarding the indications to therefore MIS, I would say personally it may be considered for nodal staging or evaluation only, not for the radical hist itself. And until we have the results of the ROC and the ROC results are published, this should only be practiced in clinical trial settings. Perhaps you can argue that in patients with previous cone biopsy rather than cervical biopsy, as shown in the subgroup analysis of your JCO paper, perhaps in those patients it's more safer to perform MIS radical hist.
Yeah, so I think I would only add to that, and certainly some of the reasons that you spoke about. Again, I think there are many who would argue that are certainly not valid reasons, but understandably, those are the reasons some may still perform MIS. The concept of, well, in my experience, it's still fine, without really having any concrete data to support that, or I can select this patient or that patient that may potentially be a candidate. When those reasons may not be, certainly very concrete or evidence-based. I do agree with you, certainly there is still the question as to whether, patients who have microscopic disease, who have negative margins on a conization, there are some who might argue, well, those patients may benefit from MIS, but obviously that not brings in the element of the shape, and we'll talk a little bit about that in a few minutes with regards to, well, those patients don't need a radical hysterectomy, and then what's the approach for the simple hysterectomy, right? So with that, then let's discuss the issue of major complications. In the LACC trial, there were no differences in major complications between MIS and open as a global evaluation, as you mentioned. We see a similar finding now as a surrogate of this time period reflection in practice. Why do you think this is the case?
Thank you, Pedro. Well, first, you cannot argue with the results of the Obermeyer analysis of the LACC trial. It is a randomized controlled trial. In the open rad-his, you have more wound complications, which I guess most were minor, and any cardiac adverse events defined in the protocol of the LACC as bradycardia, arrhythmia, hypertension, postural hypertension, sinus and supraventricular tachy, and post-infarct angina. Again, I guess most were minor. In fact, in our study, the only major individual complications which was higher rate in the open surgery was deep surgical site infection, 0.7 versus 0.2, with a p-value of 0.048. I would just say that level 1 evidence indicate that major complication is similar between MIS and open route, and this is supported by large retrospective studies.
So now, as a follow-up to your recent point on wound infections, this is one of the questions from our fellows, And it was, certainly this study highlights an increased rate of wound complications in patients undergoing open radical hysterectomy. In your opinion, what best practices would you suggest for clinicians to minimize this risk and improve patient outcomes?
Thank you, Pedro, and for your fellows in the journal. Well, it's best just to follow ERA's guidelines, basically meaning adherence to preoperative chlorhexidine shower and skin prep, adequate prophylactic antibiotics. Pertaining to this, there might be new data that adding metronidazole might be beneficial. Glycemic control, strict glycemic control, keeping normothermia during surgery, and using a separate closing tray. You can also argue that patient education is extremely useful regarding the wound care. And although this population of cervical cancer are usually not obese, obesity should be taken into account, nutritional status as well. And of course, surgical technique and strict hemostasis might help in reducing those complications.
Yeah, and I will attest to that. Certainly here at Houston Methodist, we've implemented a surgical site infection prevention bundle, and particularly, obviously, in patients undergoing laparotomy, it will definitely benefit with a significant decrease in surgical site infections. So certainly encourage those of you who might want to look into the details of that plan and that initiative. It's been recently also published in the International Journal by Dr. Lucia Ribeiro as well. So now, one of the other questions from our fellows is, other complications associated with radical hysterectomy involve bladder, sexual, and bowel dysfunction secondary to possible autonomic pelvic nerve injury, even when correct nerve-sparing surgery is performed. Do you think open radical hysterectomy can be associated with a higher rate of these complications compared to minimally invasive radical hysterectomy?
Thank you for this question. It's an interesting question indeed. I'm personally not familiar with literature regarding autonomic nerve injury in MIS versus open radis. We know that, as you said, there is the nerve-sparing technique, identification of the uterine vein, preserving the splanchnic nerves, and isolation of the inferior hypogastric nerves below the uterosacral ligament, preserving the afferent vesical branches in the lateral aspect of the bladder when you develop the bladder flap. I might say that in MIS, in robotic surgery specifically, only in robotic surgery, there is a better vision. We can argue, but I think there is a better vision in robotic surgery. And this is something that would be interesting to prospectively study, whether there is a decrease in autonomic nerve injury. Maybe the results of the ROC and the RAC trial will show something.
Yeah, and I think, I agree with you. I think that, when it comes to the bladder and bowel dysfunction, likely is the extent of the procedure rather than the approach of the procedure, because obviously one would argue that if you do an open modified radical, nerve-sparing radical versus a minimally invasive, non-nerve sparing lateral extension of the parametrium resection, then of course, obviously the MIS is going to be associated with a higher nerve, potential nerve impact on bladder and bowel function. So I think it's more so the extent of the procedure rather than the approach to the procedure. Now, Gabriel, another question from our fellows. The question is, to the best of my knowledge, it's not clearly established what type of incision to be made on a radical abdominal hysterectomy open, a midline vertical incision or a horizontal incision like a Phanon-Steele or a Maillard. Do you think that the type of incision can influence the postoperative complications, particularly wound complications?
Thank you for this question, Pedro. And I would like to ask you at the end of my answer, what is your approach? In the LACC trial, midline vertical incisions or transverse incisions were allowed and performed. We know that midline incision is associated with shorter operating time because you have a better exposure and vision, but this comes on expense of pulmonary complications and pain control issues. Some may say that hernia rates may also be higher in midline incision as well. And I agree this is an interesting point to study prospectively. And if I may ask you, Pedro, what is your preference in RADHIS?
Yes. So my approach actually is usually a churning incision. Of course, obviously that's a low transverse incision. And certainly that preserves the integrity of the rectus abdominis muscle. It actually also protects the vasculature of the rectus abdominis muscle, and the inferior epigastrics are preserved. So that's typically my approach for a radical hysterectomy or a radical trachelectomy. I usually do the churning incision. Certainly, I think that as a second choice, I would generally go with a fan and steel incision, which I think would be an appropriate incision as well. But I think, certainly, and particularly if the uterus may be a larger uterine specimen, then I prefer the churning incision. You get much better exposure to the lateral pelvic side wall. I think it will be exceedingly rare that we would be performing a midline vertical incision for an open radical hysterectomy.
Thanks.
So now let's move on to the reoperation rates. One of the questions from our fellows is, I thought it was interesting that the rates of reoperation were higher in the period before the LACC trial. In other words, in the period when MIS radical hysterectomies were predominant. Why do you think these are the findings?
Thank you. Well, I do agree this is an interesting finding. We have 2.7% versus 1.6% in our data, with a p-value, however, of 0.042. On the other hand, when you look at our analysis of open versus MIS RADHIS, we do show this in our paper, regardless of the time period, we have a 2.5% of reoperation in MIS versus 1.9, which is not significant, 0.244. You can see in the supplementary table number 6 in our paper, the analysis can maybe infer that in the MIS you have higher rate of ureteral injuries, and in the open radical hyst, more surgical wound complications that necessitate retake to the OR. I agree, this is an interesting point. However, when you take it by root, open versus MIS, we didn't see a significant difference.
Okay. Another question from our fellows. She asked, overall, the data shows that open radical hysterectomy already has few complications despite its radical nature. First, why do you think this is? And then also, any suggestions as to how we can further reduce complications?
Well, thank you for this question. In case you or the fellow meant intraoperative injuries, I think that ureteral damage is avoidable in most cases, at least in many cases. However, the rate is 1.6%, I think, in the LACC trial. Same might be true also for vascular injuries. These injuries might be avoidable by implementing best surgical techniques, knowledge of the expected anatomy, and of course, surgical experience. This was probably aid in reducing intra-op complications. Regarding the post-op complications, just follow the ERAS guidelines and continue to study measures to improve as bundles, as you just suggested. It is probably that open RADHIS is a safe procedure with few complications.
Yeah, absolutely. And I think, again, it goes along this next question with regards to ERAS and the recommendations for ERAS. The question is, certainly the first publication in 2016 and subsequently updates of the ERAS recommendation for gynecologic surgery, it's becoming increasingly more implemented worldwide. Do you think that this had any effect on the results of your study?
An excellent question. Thank you. This is a retrospective study. It is possible that this issue influenced the results. You can compare in our study the analysis of pre and post LACC and the analysis of open versus MIS, and you can argue that there are mild differences, that you can hypothesize that there are Although you perform more open surgeries after the LACC trial, there are more implementations or implementation of the ERAS guidelines, and therefore the results are as they are. It is difficult to say, but we know that ERAS is efficient in reducing complications, and we know that open radical his is quite safe, and the complication rate didn't change. I guess that only if you like to study this question is again randomized controlled trials in which the same measures of ERAS or post-op management of patients should be performed. As for now, it is one of the confounders that we cannot account for.
Very well. So now, I guess this next question is a bit more of a speculation or obviously point for discussion, but as I'm not aware of a similar study at a global level, but certainly you showed that in 2022, 11%, only 11% of radical hysterectomies were being performed through a minimally invasive surgery approach. Do you consider if you ran this same study at a global level, would you see that same minimal rate of minimally invasive radical hysterectomies?
Excellent question. Practice is so different on a global level. Also with pertaining to complications, patient care and infrastructures differ significantly between high-income and low-income countries. It would be impossible to derive conclusions as too many confounding variables in a retrospective collection of data. What we can do we should strive to standardize patient care, to narrow the gap between low and middle income countries and high income countries, to strive for adequate surgical theaters, trained surgeons, and for modern radiotherapy techniques, and to budget the implementation of ERAS worldwide.
Yeah, no, I agree with you. And I think, certain, as you mentioned, there's so many confounding factors. And of course, obviously, I think that there's going to be regions where open radical predominates by simple necessity, obviously, because
exactly.
there's no minimally invasive tools to even consider it. And in other countries, of course, there are groups that continue to perform minimally invasive surgery despite the level 1 evidence. So there's so many factors that I would love to see what the global rate is, but yeah, as you mentioned, it's really probably very challenging to study. So now, Gabriel, let's come to the last few questions of the podcast. What do you see as the limitations of this study? Of course, obviously, you mentioned some of the limitations of the previous studies that had looked at trends in radical hysterectomy. What can we talk about in terms of the limitations of our study?
Yeah, thank you. Well, there are limitations, right? We're not perfect. This is a retrospective analysis. We also have some database limitations in the ENSCIP data. We have no patient-reported outcomes. The follow-up is only 30 days outcome in the ENSCIP. We don't have hospital-level data as a procedure volume or surgeon expertise. So this is a major confounder. We do not report the rate of robotic versus laparoscopic. We know the differences between practicing robotic at MIS and straight stick laparoscopy. And this study is being based only in 49 states in the US. So it's difficult to generalize these results on other places of practice.
Yeah, absolutely. And I'd like to just again reiterate and highlight that, although certainly all of those elements that you mentioned are important elements, they were not included just because these are not available in the databases as a potential, obviously, limitation of these databases, and then of course, obviously, as a limitation of the studies that use these databases. So now, Gabriel, certainly last question, and I think this question continues to come up in the last few months. Given the results of the LACC trial, and more recently, those results of SHAPE, where indications for radical hysterectomy continue to decrease. Now, of course, obviously, we know that from the SHAPE trial, select patients with low risk cervical cancer, less than 2 centimeters, less than 10 millimeters of invasion, less than 50% invasion by MRI, those patients could definitely undergo a simple hysterectomy rather than a radical hysterectomy. So my question is, what are your thoughts on surgeon proficiency in performing radical hysterectomy overall, where we're really now coming to an indication of just patients between 2 and 4 centimeters, primarily for the most part?
Thank you for this question, Pedro. Well, I guess we're gonna hear about it more in the IJCS and more in the future. This is an example where science and studies actually may decrease our expertise as surgeons, because surgeons now have less indication to do radical his, of course. They will have fewer opportunities to practice and refine their skills, leading to decrease in proficiency over time, and it might be becoming even sooner than we think. Surgical training programs might need to adapt to this situation, incorporating maybe alternative training methods, simulation, just to ensure that residents and fellows still gain adequate exposure to radical his techniques. But absolutely, I think the landscape of course, the indication to performing radical his, and we will see a decrease in the rate of radical his in the future, with major implication on the surgical expertise.
Yes, absolutely. And yes, you're absolutely right. I will hear more about that in the upcoming IGCS meeting. And also, actually, I should also alert our audience that we're going to have a discussion at the ESGO meeting in Rome in 2025. Marie Plant is leading that session. I will be speaking, and Dr. Rene Pareja from Colombia will also be speaking on this specific topic as well. So I look forward to seeing all of you there. Gabriel, thank you so much. Once again, congratulations on this massive work. Of course, obviously, we're all very impressed by the amount of time, effort, and dedication that you put into this work. Congratulations to all of our co-authors as well. Thank you for accepting the invitation to speak with us here at IJGC, and look forward to future publications with you and by you for future podcasts as well.
Thank you so much, Pedro. And again, as you said, thank you for all the co-authors, Jason, Brian, you, of course, you're a great mentor. I don't know how people know, how much they know how it's great working with you. And Dr. Meir from Cedars Sinai as well, great researcher. Thank you so much, Pedro.